Okay, let's go ahead and start. Are you guys ready? Okay. Okay, it is my pleasure to have one of the most awarded cardiologists on this campus to come every November, as far as I remember, to give us a talk. And usually his talks are very controversial. So Dr. Vallurupalli is not a regular cardiologist. First of all, he's a nutritionist. So he has all kind of the passion about what we do. So that's one of the reasons he really joined us all the time in November. He's an associate professor of medicine at UMS, a staff cardiologist with the UMS and VA hospital. And as a non-invasive cardiologist, he specializes in cardiac imaging and also management of the complex cardiomyopathy. He completed his internal medicine residency at the University of Illinois at Urbana-Champaign and his cardiology fellowship at UMS. He directs cardiology fellowship program and cardiac non-invasive lab and also clinical cardiology operation at UMS. He's one of those cardiologists that I've known actively involved in the research, a lot of clinical and also the basic science. And also he has published more than 100 publications. So please join me to welcome Dr. Vallurupalli. Thank you very much for your.
Thank you so much. Thank you. Appreciate that kind invitation. What I hope to do in the next 40 minutes is to talk about nutrition and congestive heart failure. I think heart failure is a significant health and public health problem. Quite a bit of misconceptions out there. So what I hope to do is to help you look at heart failure a little differently than what most people think about heart failure as being. I'll go through a few slides so that none of us go to jail here first, right? So first, that's the UMS disclosure policy. It states that we're doing this in a balanced, independent, and objective way. And nobody who is planning this meeting or me have any disclosures with ineligible companies. As most of you know, it's hard to have a disclosure with nutrition. Nobody seems to care that much about nutrition. I wish we all had disclosures to disclose about nutrition, but we don't. So there are no financial relationships. This is UMS is accredited by the ACCME. So those of you who are looking for CME credits, ACPE credits, or nursing credentialing center credits can apply for that. These are the designations. I guess it's 1 hour of CME here. If you want to claim credit, this is the SurveyMonkey link. The evaluation closes on the 27th of November. Please do so. I think that's important for any CME event to get enough evaluations in. That's the QR code. I'll leave that in there for about 5 to 10 seconds for people to use and get the website on. I know the students are all like, one day, not today. We'll get continuing education. But yeah, that day will be here soon, I promise. Very good. So the objectives for my talk are these. When you talk about heart failure and nutrition, I want to it is a surprisingly broad topic. Even though you may not see a whole lot of studies on this, it's a very broad topic. I want to talk about heart failure syndrome beyond being just a fluid overload or a salt excess syndrome. I want to talk about it as a protein energy malnutrition syndrome and a nutritional deficiency syndrome. We'll talk about how heart failure affects a body and nutrients and nutrition. And we'll talk about some strategies on improving nutritional management of heart failure. Now, I want to start off with the basics because I know when people think about heart failure, we have different ideas. First off, heart failure is a significant problem. Just in the US alone, there are 6 million people living with heart failure, right? That's a big problem. In the past, this disease was worse than most cancers. So in the past, if you're diagnosed with congestive heart failure, at 5 years, half the people were dead. Nowadays, most terrible cancers, more than half people are alive at 5 years, meaning that heart failure is a significant health problem. And there is a significant burden to society, both in the form of hours of work lost as well as the cost, simply the cost of heart failure. Now, when you think about heart failure, there are two important things to realize. One, your heart is either not pumping effectively, so it's not pumping enough blood simply because it's a pump that's tired out, or it's a pump that's so stiff that it accepts very little blood into it. If it accepts very little blood into it, it can't pump enough blood out. So it's important to realize that when you think of heart failure, most people think of this particular cartoon, right? The whole heart is big and baggy, and whereas a lot of what we see now is a heart that looks kind of like the cartoon on the left hand side of the screen, a heart that is very thick. Both of these are significant problems. Now, whenever you're reading about heart failure, it's important to realize that these are the two major types, one with a low ejection fraction or pumping function, and one with a normal ejection fraction. And among those with ejection fraction reduction, we talk about normal being 50 to 70%. And let me get my laser pointer so that everybody can see. Okay, good. So 50 to 70% is normal. So if you have heart failure with a normal ejection fraction, it means your heart is pumping okay, it's just too stiff. It is not accepting blood well enough. And then as the pumping fraction goes lower, you start developing the more classic heart failure with reduced ejection fraction. So you have three major types: heart failure with preserved ejection fraction, 50 to 60 being normal; reduced ejection fraction, which is less than 40%. And just like in life, there is always a gray zone. 40 to 49%, we call it mid-range ejection fraction. The reason I'm telling you all this is when you read about heart failure and nutrition, each of these diseases behave a little differently, because a failing heart that does not pump is not the same as a stiff heart that can't receive blood and is just not being able to relax enough to accept all the blood. Now, when we talk about heart failure, most people, when they in their mind, it is something that looks like this: patient is huffing and puffing, can't take breath, swelling up, and those are the patients we usually see in the hospital. But what we've realized over the past 20 years is that there are different stages of heart failure. At the beginning, most patients who will develop heart failure at a later stage have several risk factors that are predisposing them, but they don't have any changes in the heart. And then the heart starts changing, but it is able to adapt to those changes. And patient's asymptomatic, but when we look at it on an echocardiogram, we can tell this heart is too thick, it's just not working too well. And then they start having mild symptoms where they get short of breath and fatigue. And finally, it can go on to a stage where they start swelling up and start getting admitted to the hospital. So these are stages A, B, C, and D. And the reason I'm going through this is when you think about nutrition, overnutrition and undernutrition, these are problems that are different at different stages. So it's important for you to know when somebody says stage A heart failure, this is people who are otherwise healthy. They don't have any symptoms, but they have risk factors. So the way you manage nutrition in them is different than a patient who is huffing and puffing in the hospital with a weak heart muscle. So let's talk about something that we all kind of are attuned to outside of heart failure, and that is overnutrition or obesity. Very common problem in the society, right? Obesity causes about 10 to 15% of cases of heart failure. As simple as that. Especially heart failure with a normal pumping function. Meaning, if you think about it, if you just have too much adipose tissue in your body, you have all these tiny blood vessels that the heart has to pump blood to. To adapt to that, and to adapt to all the fat and the restriction of the thorax on the heart muscle becomes stiff. Even though it's pumping normally, people start huffing and puffing, developing fluid overload, because even though the heart is pumping normally, there is quite a bit of body for that same heart to supply blood to. That triggers the same hormones that cause shortness of breath, fluid retention, and everything that looks like heart failure. So when you think about heart failure from obesity, this is typically a predisposing condition, meaning obesity predisposes to heart failure. And it does so in many, many different ways. What we usually think about is typically something that's on this side. You have obesity, insulin resistance, which predisposes to inflammation, oxidative stress. Simply having too much glucose and lipids in the body is toxic. Being obese leads to people not breathing well enough, their oxygen carrying capacity is reduced, and all of these metabolic abnormalities can cause heart failure. So at this stage, stage A, it's straightforward, right? Obesity causes heart failure. So treating obesity, nutritional advice and nutritional management that reduces obesity is very important. But what happens when people actually have heart failure, meaning stage C or D? Their heart has already failed, they're huffing and puffing, and they're right now in front of you. What does weight do in that particular situation? In that particular situation, we have a very interesting paradox, and that's called the obesity paradox. We've known about this for about 30 years now. What happens when you develop heart failure? And this is a more recent study, so it's stratified with reduced ejection, preserved ejection fraction, mid-range, and reduced ejection fraction. In all three of these subsets, if you look at BMI in the x-axis versus outcomes, which are mostly mortality in the y-axis, you see this curve where there is a sweet spot for the BMI. If your BMI is too low, your mortality is actually higher. If your BMI is very high, surprisingly, there seems to be a neutral effect on mortality. So the paradox here is obesity causes heart failure, but in patients with heart failure, being obese does not seem to be a bad thing. Whereas being underweight, BMI less than 18.9, is a significant risk factor for mortality. And this has been the obesity paradox that everybody talks about in heart failure. So how can we explain something like this? So the most important thing to remember is obesity is not equal to good nutrition, right? An obese person can be terribly malnourished. Consuming empty calories and gaining weight does not mean that you have all the nutrients you need in the body. What we've learned in the last 10 years or so is very interesting. If you look at patients who are obese, and you look at and you divide them into different quintiles, you can see here BMI more than 35, 30 to 35, 25 to 39, and BMI less than 25 on the x-axis. If you look at people's nutrition status, and in these studies, most of them use something objective, so you can actually measure it and reproduce it. One of the most commonly used indices is called the PNI, Prognostic Nutritional Index, which essentially looks at your serum albumin and your lymphocyte counts. It's a product of that with a standardized regression equation. If you have across all of these body weights, if your nutrition status is not good, you have worse mortality than if your nutritional status is important. Meaning, you got to look beyond the BMI in patients with heart failure to figure out why obesity does not seem to really affect prognosis once you have heart failure. What this also means is, once you develop heart failure, BMI is not as important as your nutritional status. Okay, so automatically seeing a patient with heart failure, BMI is 34. Oh, we got to help you lose weight, cut down calories. Let's start you on medication that prevents your appetite from making you eat so much, may actually be the wrong thing, because an already malnourished patient may become more malnourished. So this is a very important thing for us to recognize. And then across all the spectrum of heart failure, you can see that the nutritional index is, there is a significant number of patients across all three of these which are below a normal nutritional index, or the incidence of malnutrition is the same regardless of the type of heart failure. And across the BMI spectrum, the number of patients with, if you have low nutritional index, your prognosis is worse than if you had normal nutritional index. So basically, what all of this says is look for markers of nutrition, not BMI in heart failure. Now, what happens if you're malnourished in heart failure? How big is the problem? This is a meta-analysis of all the studies to date in 2021, looking at how prevalent is malnourishment or malnutrition in heart failure. And pretty much across the board, you see it's about 50%, right? 1 in 2. You meet a patient with heart failure, 1 in 2 of them, regardless of their BMI, will be malnourished. So significant problem, right? I think we could easily say that. And why is that an important problem? If you have heart failure and if you're malnourished, across the board, all the studies that were included in this meta-analysis, every single one of them essentially gives you an average doubling of your mortality rate if you're malnourished compared to if you're not malnourished. So significant problem affects mortality. So we need to understand why these patients are malnourished and what we can do about it. So why does heart failure cause malnutrition? This is the kind of slide that puts people to sleep usually, right? There is a lot to look at. But it's such a complex topic. I want to show you that if somebody tells you, I know exactly why this patient is malnourished, they're probably wrong. Because the human body is not a science experiment. There are so many things at play. But let's look through just at least a few of these so that you understand why a failing heart puts somebody at risk for malnutrition. A failing heart causes inflammation in the body. When you have inflammation in the body, the most important thing that happens is you start breaking down protein, high catabolism, right? And very importantly, what we recognize in most patients with heart failure, it kills your appetite. The killing of appetite is not just because somebody is sick. You often see family members with very good intentions telling people, oh, you got to eat for your strength. It's not that the person is refusing to eat. It's not that they're depressed. Basically, all of this have significant and well-established molecular basis for why their appetite is low. These are actually changes in axes in signaling of molecules like leptin and ghrelin. And when you have this type of scenario here, it leads to muscle wasting. And that muscle wasting and physical inactivity contributes to malnutrition in a circular kind of way. The second thing that patients who have heart failure have, in addition to inflammation, is their body is revved up to keep them going, right? It makes sense. If your tissues are not getting enough blood, the body produces a lot of adrenaline to keep things going. And when you have increased adrenaline, it also activates renin, angiotensin, aldosterone. And what that does is two things. It causes vasoconstriction, meaning your blood vessels are all clamped down, so your gut does not get as much blood. If your gut doesn't get as much blood, guess what? Appetite goes down. Its ability to accept enough food goes down. So that is one of the significant things we also see. And then when you have volume retention, the gut also thickens up. Your stomach essentially becomes swollen. And the first thing patients come in and say is, I lost my appetite. And that's usually the first sign they're going back into heart failure. Both of these cause malabsorption. And when you're not absorbing nutrition, whatever you get into the intestine is not going to go in. So that causes both macronutrient and micronutrient deficiencies. And with this volume retention and with some of these states, the first thing we start talking about in these patients is, let's cut back on their sodium. Let me back up 1 minute. Let me only put our students on the spot. When you heard the topic of this lecture, how many of you thought we're going to go in there and we're going to learn about salt restriction? Show of hands. Pretty much everyone, right? Because for us, this is all it's drilled into our heads. Heart failure equals sodium restriction. Now, let me make you think about it in a different way. If you restrict sodium, you're thinking, I'm helping the patient, right? And this has been proven over and over and over again. The minute you prescribe a sodium restricted diet, the dietary intake goes down. Calories and sodium, they kind of go along together. You reduce the sodium, your caloric intake goes down. Now, you could argue, well, I can cook food that's very delicious, blah, blah, blah. I'm talking about a general overall population. You talk to an average patient, say, cut down salt. They'll look around, they'll try to do the right thing. And by cutting down salt, they'll cutting down their calories. And so when you do that in a patient who is already prone for malnutrition, this is a significant contributor to insufficient dietary intake leading to all of this stuff. So you can see how heart failure does things to the body, makes you malnourished. Our reaction, or sometimes overreaction to heart failure, contributes to the problem. So salt restriction, and we'll go over it a little bit more so that we can discuss what it is that salt restriction does in this population. Busy slide, but the only reason I'm showing you this is to show these are the common therapies that we use for heart failure. We use diuretics to help people pee out fluid. We use beta blockers. We got ACE inhibitors. All of these have been shown to actually cause nutritional deficiencies of some kind. We all know about diuretics reducing potassium. Simple, right? You give somebody a potassium pill. But how many times do we sometimes look at hypomagnesemia, we measure it, but it's ridiculously hard to replete magnesium through a pill. Easier to do it IV. But how many times do we think of these? Thiamine deficiency, well known to occur with loop diuretic use. Calcium, low calcium with diuretics, and also something that we are recognizing more and more in heart failure is deficiency of zinc. Now, zinc, when you go to average rehab, we check zinc and selenium levels all the time to look for wound healing, but zinc is also an important part of cardiometabolic health. So the treatments we use for heart failure can cause significant micronutrient deficiencies as well that if you're seeing with a patient with heart failure, need to consider, especially when you're trying to prescribe a particular diet or a particular intervention. So knowing all of this stuff, how do you approach a patient with heart failure, and how do you come up with a strategy that works for that patient? So first off, you obviously have to talk to somebody, right? That's the hardest part of in all of healthcare is talking to somebody. If you don't take time to sit down and talk, you never understand. You start throwing out cliches almost. Cut down your salt. Well, how do you know how much salt they actually eat? Talk to the patient. Always talk to the patient. So you want to talk about how they're doing. You want to know about these three important things. Are they already reducing their intake? Because the advice you give them can actually be harmful if they're already not eating too much, right? Have they already been losing weight? How is their physical capacity? And on physical examination, you could do things like muscle wasting, measuring their upper arm circumference, so on and so forth. But a lot of the laboratory data that you need to assess malnutrition is routinely measured in patients, especially in the hospital. So looking at the albumin level and the lymphocyte count, you should be able to just be able to diagnose malnutrition, but more importantly, even come up for research purposes, for quality, if this is something that somebody is interested in. These labs are present in every heart failure patient. So a great way for you to figure it out. And then you want some type of a tool that helps you assess their actual status, some type of diagnostics. Now, unfortunately, to do things like DEXA or quantitative MRI is mostly a research realm thing. It's not really relevant for clinical practice. But doing some of these, like a mini nutrition assessment or a geriatric nutritional risk index, because heart failure is unfortunately an old person's disease, is always useful. And then when you're counseling them, always think about what we discussed with malnutrition. Establish reasonable caloric goals, right? You don't want to lose weight. You don't want to lose muscle. You want to talk about, and this is from a cardiologist perspective. So you see, refer to a registered dietitian as somehow it needs to be mentioned. It should be automatic, but our healthcare system really does not, unfortunately, make it that simple. In the hospital, yes, but in the clinic, it surprisingly seems to be a lot of resistance to it. And this is the type of thing that needs to be concentrated on. These patients, a lot of times, actually need high proteins. They actually need some of these calories because you're dealing with a catabolic state, right? The key is to prescribe the right kind of calories and right kind of protein. And when you look at all this, look at what seems to be missing and what is actually added into this list here. There is nothing here about, crack the whip, make sure they don't eat salt. And there is this very interesting statement, liberalized diet, right? Quite the opposite of what we think we should be doing in heart failure. Because remember, by the time they have heart failure, it's a completely different ball game. It's a malnutrition state 1 in 2 times. So you actually are often talking about, how can I get this person to eat something? And this is an important thing for us to recognize. In fact, just in the clinic today, I was seeing a patient, and she was surprised when I asked her this. I was seeing her for the first time. She had heart failure for almost 6 years. She was 88, very frail. And I asked her, what food gives you the most joy? And she kind of looked at me. I mean, she thought I was joking or something like that. But my point to her is, look, you're losing weight. I just want you to not lose weight. What gives you the most joy? And of course, the daughter starts smiling and says, chocolate. And so there you go. If she likes the taste of chocolate, maybe chocolate milkshakes, something that can allow her to consume good enough amount of calories, good enough amount of protein. So that kind of liberalization is important rather than to be fixated on a particular diet, because we really don't know what diet works on a majority of patients. And then I just threw this slide in here just in case if those of you are interested in research or other ways in which you can measure all of these things. Do some type of a test that you can follow over time. It could be something like an assessment tool, a dietary assessment tool. It could be a lab test or what have you. Once you prescribe that, following the patient and making sure that their weight, BMI, or more importantly, since we said weight and BMI are not very good tools, looking at something like albumin, pre-albumin, or a lymphocytic count are very important in their practice. So let's just get this part out of the way, right? The salt nutrition part. I just want to, and again, I don't say this because I'm dogmatic or I somehow think that we all need to go swim against the grain. There is simply no evidence that a particular amount of salt restriction works in treating heart failure. There simply is not. Studies that were reasonably well conducted show very varied results depending on the population that is included. Meaning there are definitely some patients who overuse salt and need salt restriction, but there are definitely patients where when you prescribe salt restriction, they get worse. They get hospitalized more and they die more often. And people have often thought, what is it about salt restriction? It seems so intuitive, right? You're swollen with fluid, just cut back on fluid and salt. You should do well. And this is what I was mentioning before is when you cut down on salt intake, your caloric intake goes down. So on the x-axis here is the sodium intake that is estimated. On the y-axis is a measure of the estimated intake of calories versus the need, meaning 0 is good. You're consuming exactly the amount of calories that you need. If you're positive, it means you're consuming way more calories. If you're negative, it means you're not consuming enough. So you see the sweet spot is somewhere here, right? Somewhere around this area. Look at all these patients and look at all these patients. A high salt diet is often high in calories. I think that's safe enough to say. But restricting salt also seems to restrict the amount of calories one can consume. Is that just the Western diet? Is all our food choices and tastes so heavily influenced by salt that the minute we cut down salt, we have left with no options? Could be. But also, reducing salt by itself changes taste, reduces appetite, and interestingly enough, increases the perception of thirst. Right? I'm sure you've seen this in yourself in the summer, right? The minute you get dehydrated, you get salt, you start feeling thirsty. Same thing happens if only thing you do in a day is drink only water. Sometimes water just doesn't cut it, right? You got to have that bottle of Gatorade because low salt intake also causes increased thirst. And when your thirst is increased, guess what? You don't have an appetite, right? You just want that bottle of Gatorade. You don't care about eating a hamburger when you're thirsty. So that's another reason why to think of salt restriction as not being a universal truth in heart failure. This is a meta-analysis of all the randomized controlled trials looking at low sodium versus high sodium diet in heart failure. Somewhere in between is unity, meaning that one is not better than the other. And here you can see, depending on different study designs, all of these studies essentially show no difference. Not that high sodium is good, but low sodium is not better than high sodium, meaning this syndrome is complex enough that you can't just pin it on salt. So think of sodium restriction as being something that is useful in some patients, but not a cliche that you throw at every patient with heart failure. Now, what kind of diet should these patients eat? How do you get them a high quality diet? If you had to bring out one brochure for your patients with heart failure, what would that be? Anybody? What is an ideal diet? Mediterranean diet, fantastic. Any other words? Any other? TLC. All right. Any other diet? What is the diet that we often prescribe for high blood pressure? DASH. Surprisingly enough, there is a lot of data that DASH diet not only prevents heart failure, it actually improves outcomes in patients with heart failure. Now, let's first talk about what a DASH diet is, right? What is this magical DASH diet? It's basically a predominantly plant-based diet, Remember, the minute you start giving dietary prescriptions, a lot of very angry and overzealous people come out of the woodwork, right? For some people, plant-based diet is almost a religion. I'm talking about a predominantly plant-based diet. Because remember, plants, very dense in nutrients, but not as calorie dense. So if you want to get good nutrition without being over caloric, this is exactly what you need to do. Now, obviously, some of these are also controversial. Should dairy be low fat? I don't think there is any evidence for that. I think regular fat dairy now we know is as good as low fat dairy. But the principle of the matter is really what matters. I think this is the important thing when at least I feel when I talk to patients is don't get fixated on the details. Think about the principles. The principles are eat more plants, avoid stuff that is refined and comes from a store. Simple enough, right? Simple enough if you can afford it and you can get those kind of groceries every time. But I think this is very, very important. And what studies have shown, even in heart failure, is that a DASH type of diet, surprisingly, a lot more studies on DASH diet in patients with heart failure. I'm not talking about preventing heart failure, but with heart failure, does pretty much the same thing it does in hypertension. Blood pressure goes down a little bit. Some people lose a little bit of weight, not that it's necessarily healthy in all patients. LDL comes down. Very interesting study showing that the heart muscle function in these small studies actually gets a little bit better. And exercise capacity goes up, and the quality of life also goes up. So if you want to give them a general principle, use the word DASH diet, because I think most people are very familiar with that. And the reason why I specifically say this is this has some of the best data supporting it in heart failure patients. This is the so-called Gourmet HF trial. Have people heard about this trial? Very interesting study. Gourmet HF was not just a DASH diet, it was a home-delivered DASH diet. You came into the hospital with heart failure, and we say, you know what? We need to keep you out of the hospital. We don't trust what you cook at home. So we're going to send you a package of food that you will eat every day. We're going to do it for 12 weeks. Let's see what that does. Now, at 12 weeks, you really can't assess if people are going to live longer or what have you, right? So you look for surrogate outcomes. And what this showed is the following. The Kansas City Cardiomyopathy Questionnaire is a questionnaire for how people feel, quality of life in heart failure, how their symptoms are. The higher the score, the better they're feeling. You can see that the DASH diet here has much better scores at 4 weeks than the regular diet. So I think that is something important. More importantly, by following this diet, people stay out of the hospital. Everybody got very excited. So guess what? Why is this not standard of care yet? This was published in 2018. The cost that is associated with this. And this is where rubber hits the road. This is not a paternalistic, we're going to control your every moment in life and keep you out of the hospital. It's important to make a positive change in patients by helping them understand what their health is and what they can do to help their own nutrition at a reasonable cost. Now, the most important question people always ask is this: isn't a DASH diet already a low sodium diet? Maybe the DASH diet is working because if it's low sodium, right? Because whenever I say I smile at salt restriction, all my colleagues in cardiology is like, okay, here he goes again, doesn't want people to restrict their salt. The point is a DASH diet truly a salt diet? And is there any benefit to adding salt restriction to a DASH diet? So remember, a DASH diet can be high in salt depending on your culture, right? So if you're eating beans, I can make beans in a healthy way. I can also make it in a way that is very high in salt. So DASH nutrition diet does not mean low salt diet. So is there any benefit to adding low salt to a DASH diet, right? And we don't have a whole lot of data, but this I thought was very interesting, and I wanted to share it with you because everybody asked me the same question: why should salt restriction be a problem? I can understand it doesn't help, but how should it hurt, right? This is a small study, a usual controlled nutrition study, right? People are there, you know exactly what they're eating. They're not going out and eating chips while you're not watching, right? Very controlled nutritional study. So what these people took, they took quite a bit of people, about 412 patients, randomized them to a DASH type of diet versus a typical American diet, whatever that means. But I think we all know what it means, right? And also, over a couple of weeks in each one of them, had them take low, medium, or high salt intake. So each patient is their own control, right? And what they found with this is this is just a biomarker type of study. What they found is this: if you just give people a reduced sodium diet, right? Doesn't matter if they're eating a typical American diet or a DASH diet, right? If you only give reduced sodium diet with a typical American diet, you don't have any change in cardiac injury. Their heart is a little less strained because it's not swollen with fluid. But look at what happens with inflammation. It actually goes up. If you do a DASH only diet without prescribing sodium, you see that injury goes down, their inflammation goes down. Now, when you add DASH plus reduced sodium, you seem to have less injury, less strain, and you're just negating the effect of reduced inflammation from a low sodium diet. Now, obviously, not very precise, right? It's a group of people. You're looking at averages across the population. But what this tells you is this: is that if I don't look at the quality of the diet and I only look at sodium, I'm getting some benefit, right? There is a little less fluid. That's why their heart is not as stretched. But I'm probably trading off for longer term consequences with high inflammation. And this inflammation, we already went through how inflammation changes leptin signaling and changes your appetite. This is one of the more convincing studies that I have seen, which show that in human beings, reducing salt intake can have downstream effects on appetite beyond just animal studies or otherwise. So this again tells you that a high quality diet is as important as just restricting sodium in these people. Then comes the more important thing, and we always discuss this at least hopefully more than once a year, but once a year is, okay, we give dietary advice. Can people afford it? What's the cost of a DASH diet? And this is where it's so important to look at the person, not just the person, but where they live, their socioeconomic status, and their cultural upbringing. Very interesting study published in 2013 from the NHANES data, which has a dietary survey. They looked at the dietary pattern of a lot of people and assigned their diet a score. The higher the DASH score, it means that their diet is much more aligned with a DASH type of diet. Lower the score means that it is less like a DASH diet, more refined foods, so on and so forth. Look at the cost per 200 kilocalories or 2000 kilocalories, dollars per. How much does it cost, right? If your diet is a high DASH diet, you can see that the cost goes up by almost $1 on an average, from $4 to 5, right? And there is a nice gradation. But look at some of the differences in how different ethnicities, by ethnicities here, really what we are thinking about is where they live, access to food, and definitely cultural I would say cultural approaches to food, where they buy food and how they cook food, right? So look at how to have the same high quality DASH diet, you have significant differences in costs between non-Hispanic whites, non-Hispanic blacks, and Mexican Americans and Hispanics. What this tells you, I mean, we can sit here, look at this and dissect it out, right? Where do they buy groceries? Is somebody going to Whole Foods versus the neighborhood Asian market where things are a lot cheaper? But also think about food deserts. How long do you have to travel to get this kind of diet? And say you go to a local gas station. If that's your only grocery store, how much more is food going to cost there compared to, say, a Walmart or a Kroger that you could go to? And this is important for all of us who think about nutrition, is to understand that we need to think about costs. Go to the UMS cafeteria. How much is a slice of pizza compared to the salad bar? I rest my case, right? How do you expect people to make the right choices when processed, refined foods are so much cheaper than high quality foods? So it's important to provide choices to your patients, and being street smart. I mean, you'd be surprised how many times I ask people in Little Rock, especially, saying, where do you live? And depending on where they live, I may know a grocery store close by where they can get produce much cheaper. And typically, it's an ethnic market of some kind. And it's important for us to know that so that we can give those choices to patients. Moving on with some of the micronutrient deficiencies, we already went through some of this, but from a nutritional management, thinking about what is it that I can test and treat to help patients' nutrition. Calcium, potassium, magnesium, we test for it routinely. If there is a deficiency, we know how to treat it. And that is very common. The things to think about are things that we mostly think about in wound healing, but not in heart failure, and that is zinc and selenium. Zinc deficiency is much more common than selenium deficiency in this population, and simple replacement can often help in these patients. Magnesium, again, very common deficiency, both because of heart failure and from the diuretics that we use. Iron deficiency is very common in heart failure. And the important thing to know is in this condition is it's not because they're not consuming enough iron. There is a high resistance to iron uptake. So no matter how much oral iron you give them, they're not going to absorb enough. So the only treatment for this, or the known treatment that helps these patients, is intravenous iron in the hospital. So that is one thing that we've tried. Oral iron supplementation has never really shown to benefit these patients. But when you give IV iron in the hospital, I think that is something that's been shown to improve outcomes in the form of feeling better and not coming back to the hospital as often in the next 6 months. We'll leave coenzyme Q alone. It's a very interesting molecule. There is actually studies showing that patients with heart failure with coenzyme Q deficiency, they seem to do a little bit better when you supplement them. But this is still very controversial, probably not ready for prime time yet. And then we talked about vitamin deficiencies as well. Look at their vitamin intake, look at their micronutrient intake, rather than just looking at salt and their diet. And I know a lot of these are very common. I want to re-emphasize thiamine in heart failure, mostly because of diuretics. You essentially pee out thiamine. Very important to keep that in mind. Most common. You can also have vitamin D deficiency, which seems to be very, very prevalent in heart failure or without heart failure. So what's the paradigm here? I want to end with this paradigm because I think in Western societies, we kind of try to use the same paradigm across the heart failure spectrum. So let's spend a few minutes on this. So if we say heart failure has different stages, in the early stages, patients who are at risk for heart failure or pre-heart failure, overnutrition is a significant problem. That is really where you are our best bet in preventing heart failure is. You work on strategies to reduce the effects of overnutrition on the body, reduce obesity, work on a healthy diet. But as they go down the spectrum of heart failure, undernutrition becomes significantly problematic. Here, it's important to understand that there is chronic inflammation and loss of appetite. You really want to prevent and treat frailty and loss of muscle, sarcopenia. You want to make sure they have adequate amount of energies and protein intake. And especially by the time they reach this stage, quality of life is important, meaning making sure that patients are living life, enjoying life, and at whatever time they have is much more important than being dogmatic about a particular level for them to shoot for. So with this, I want to conclude and with these four simple conclusions, which I hope I've made today. Heart failure is a catabolic state. You are breaking down muscle, you're malnourished. Malnutrition occurs irrespective of BMI. I hope I've shown you data. I know it's one study, but it's a very elegantly done study showing if you have heart failure, no matter what the BMI is, malnutrition is very common. And no matter what your BMI is, being malnourished worsens prognosis compared to being nourished. Salt restriction is helpful in some patients, but in most patients, it will limit caloric intake. So be careful. Use salt restriction like a medicine. Just the same way you won't give the same medicine to everybody, don't prescribe salt restriction to everybody. And focus on the quality of diet in heart failure. Having a rich diet is important. And using a DASH type of diet as a founding principle is probably an easy thing for most patients to adapt. With that, I want to leave enough time for questions, and I welcome them if you have any.
Thank you very much.
Thank you.
Any question?
Yes, please. Yeah.
Recommendations for guidelines?
So unfortunately, there are no strict guidelines for something like this. As you know, there is always a range of the amount of protein to take per kilogram of body weight. And I think this is where having a nutritional index and following some type of biomarker to make sure that the patient is not only consuming, because remember, there is consumption and there is absorption. And if heart failure causes malabsorption, you could also see how you may have to vary the amount you eat and the quality and the type of protein that you eat. The other thing that we commonly see is some patients, depending on how swollen their stomach is, can't tolerate all types of protein. So you have to explore some of these differences in them. And that's where talking to patients about what works for them is a really nice starting point. Sure.
Any other question? I have just a couple of questions.
Sure.
A lot of obese people these days, they go on multiple drugs, losing weight. And as soon as they lost weight, they go back to the regular diet and regular lifestyle. And I want to know regarding of these going up, coming down, going up and coming down, and the effect on the cardiovascular disease.
Yeah, that's a great question. Really the question is yo-yoing of your weight, right? I mean, if you go caloric restriction versus over calories and gaining weight, is there a problem? Intuitively, it makes sense that it would be a problem, right? You are bombarding the body with either pro-inflammatory, hopefully some anti-inflammatory effect of caloric restriction, though nobody has really looked at caloric restriction in the form of using a chemical like a GLP-1 agonist to essentially curb your appetite and your food intake. I think we will know in the next 5 to 10 years. I think we're still early on in the game with some of these medications. I have a feeling that the sustainability of such weight loss depends highly on individuals. Some individuals, the first time they lose weight on the medication, they're able to keep it off. But obesity is such a complex problem. I have a feeling this yo-yo effect is actually more dangerous because it's like how when people have looked at tree trunks, sliced tree trunks to look at when the tree suffered drought, right? You have a bark which tells you, oh, yeah, 200 years ago, this 1,000-year tree that we decided to cut down for science had drought, right? Even though there is not a whole lot of evidence from diet, there is evidence showing repeated stress on the cardiovascular system adds to your vascular and cardiac age. I think those types of bouts increase aging and by that I mean vascular aging, and are definitely not probably healthy.
Thanks. On the second note, a positive note, red wine and cardiovascular.
Red wine and cardiovascular disease. I know we're going a bit off topic, but actually I will make it on topic as well. Thank you for that. So for a long time, so red wine and cardiovascular. Let's ask our students. We have young people here who are not biased by age-old dogma. Red wine and cardiovascular disease. Good, bad, don't know.
Drink like 3 barrels of red wine to really get the effects that you're wanting, so like the protective heart effects.
Got it. So you're talking about if I'm consuming wine for antioxidants, I need to drink a lot of wine. It's not a glass of wine is not giving me the antioxidant. So why should wine help at all in cardiovascular disease? Let's explore it. We have time. I hope you don't mind us exploring this, because I want them to realize how these things get into common knowledge, right? How does science ever get us into this position? So how do we know red wine is healthy? How did we start off with this? We started off with this by looking at societies where people smoke, eat a lot of cheese, but stay thin and don't have much heart disease. So I'm talking about societies in Europe like France, right? And people looked at that and said, by golly, they're doing all the things that we don't want to do, but they're doing something good. That's why they are not getting as much obesity and cardiovascular disease. And we said, well, it's got to be the wine. They got this wonderful wine. And then we start looking at wine and we realize, oh my goodness, lots of antioxidants, right? That has to be it. That has to be it, right? But what we also didn't realize at that time is, wait a minute, the average French person is walking around all day, doesn't use a car. When they eat cheese, they eat a small piece of cheese, they nibble at it. And more importantly, how do they consume wine? They're not sitting at home with a box wine next to them, watching Netflix and just chugging away, right? They consume wine in a very social atmosphere, a lot of joy. When you look at the studies after that, when people stop smoking, and you look at the actual effects of wine on the heart, really, what we now know is if you just pour red wine on a heart cell, take the brain out of the equation, take the emotions out of the equation, right? You need a lot of wine to create that antioxidants. It literally has no positive effect on the vasculature on the myocardium. In fact, alcohol in heart failure, in the past, we used to say, well, maybe it's okay. Now we tell patients zero alcohol, because consuming alcohol in heart failure with a weak heart muscle, I tell patients, is like taking a baseball bat to your heart. You're just weakening it even more. So red wine, if you consume it in a very pleasant, happy situation with friends, families, after work, in that situation, it's absolutely great for your cardiovascular health. Not because of the wine, but because it's loosening your inhibitions enough to where you're able to laugh, you're able to enjoy life. No single study that I know of, especially now, as you know, we're walking back our recommendations. Right now we say, well, we were wrong. We're never going to tell anybody to drink red wine for health. And that's good. If you don't drink alcohol, there is no reason to drink alcohol for your health. If a bottle of Coke makes you enjoy life with your friends and family, that is the positive effect of that drink. It's not because of wine by itself. So when you think about some of these myths, I want you to read history. History is a great friend, especially in the current era. We learn a lot from history, mistakes that we should never make in the future. The history of nutrition is filled with this type of wishful thinking. So yeah, if you drink a glass of wine, it makes you feel good, have at it. I'm never going to take your joy away from you, because you being happy is going to be the best thing you can do for your heart.
My last question.
Yes.
That you talk a lot about the salt restriction.
Yes.
How about the salt sensitive people?
Yes. Now, salt sensitive is people are mostly, most of our data is in patients with high blood pressure. And you will definitely see these people even in heart failure. There are some of my patients. I actually have this one patient, very classic, really likes Chinese food. If they don't watch it, this one patient actually went into heart failure at the end of their meal in a Chinese restaurant. Just started huffing and puffing. There is definitely genetics in a body's response to salt. And that is why one of the things that people talk about, which never went anywhere, was precision medicine and then precision nutrition. There should be a way in which we should be able to tell who responds in what way to a particular type of nutritional intervention. So if there is some way we can figure these patients out, because remember, by the time they have heart failure, they're on diuretics, they're on all these medicines which make our lab tests not as good for looking at urine sodium and things like that. What I think should be done in these cases and what I practice is the following. You try it. It's like a medication. Tell patients, cut down your salt in this way. Give them a practical advice. See how it makes you feel. They feel, oh my goodness, I feel great. I feel I have more energy. Follow it. They come back and say, I don't eat anything, I've lost weight, or you looked at their albumin, it's actually gone down. Liberalize it. In fact, most of the time when I see these patients in the clinic, I only tell them three things. I don't go over any of this stuff because time is valuable, right? Patient's time is valuable, your time is valuable. Only three things I tell them is eat more plants than animals, eat food that you cooked at home rather than eating outside. You can eat outside a couple of times a month, but no more than that. Third, don't eat things or prepare things that are made in a can, that come to you in a can. Because to preserve it, most of the canned food has salt in it. And a lot of the preserved foods that come in salts in cans also are highly processed, especially if you're thinking about prepared foods. So with that, it's really hard to overdose yourself in salt, right? Think of a plant dish. I mean, yeah, I can think of some, but think of you cooking at home and somehow managing to add a lot of salt to your little dish. You won't be able to tolerate it. But a restaurant making a big batch of soup can add a ton of salt just to increase the level of taste in there. And when you go to a restaurant, you almost always overeat because you paid for it. You got to finish that portion, right? And that's how you also have more salt in it. So there are a lot of behavioral things that go into salt sensitivity and salt intake. Yes.
So salt restriction, it's like medicine. So one day you go to a remission, you take that restriction away, and you're like, oh my gosh, I can do anything with salt now. Is there a ceiling and maximum on that stuff?
Yes, and so this is really one of the things that we need to emphasize is when we say no salt restriction. If you say no salt restriction without the three paradigms that I've given you, it can be dangerous, right? Go out and have a daily sandwich for lunch and dinner. Boom, there goes there goes your diet, right? A lot of really high salt diets are really processed foods. If you cut away foods that you buy in a dinner tray that you microwave and heat from a restaurant, if you cut those away, it is really hard to consume a very high salt diet. Because if you look at a lot of the economies in Asia, for example, where their ethnic cooking is very flavorful, right? When they eat food that's prepared at home, if you look at their average salt intake, it's really not that high. It's around 4 to 5 grams. All these 8 to 10 gram per day sodium intake you see are really in people who eat processed foods and things which are ultra refined, so to speak, because those kinds of foods have such little nutritional value. The only way you can make them tasty is by adding a lot of fat and adding a lot of salt to them. Otherwise, it's like eating cardboard, right? I'm sure you all tried no salt chips, right? The only way you can make that thin layer of ultra processed chip tasty, add a lot of salt and add a lot of fat in it. So high salt foods are high salt prepared foods from outside are inherently low in nutritional quality.
Any other question? Thank you very much.
Absolutely.
reserve November 2026.
Yes, if, yes, I'm sure I'll be around unless they fire me. So thank you very much. Yes, yeah.